Reducing mortality and morbidity from vaccine-preventable diseases involves successfully implementing strategies that ensure high coverage and minimize dropouts and zero-dose children. Achieving maximum coverage, however, has been a challenge due to many reasons, including high rates of immunization defaulters. One of the main reasons for defaulting immunization has been inadequate counseling of mothers, which leads to lack of information about vaccine schedules. Other reasons include unusual circumstances such as missed appointments, loss of vaccine cards, and when health workers fail to make home visits. Health system factors have also contributed to the problem, and this includes poorly arranged and coordinated immunization schedules, vaccine and supply stockouts, and the lack of viable defaulter tracking system in the health service delivery. Defaulter tracing can be described as the process of finding children who missed scheduled immunization appointments by community-based volunteers. This activity resulted in improved attendance of under 5 children, but most especially those between ages of 0 to 23 months due for vaccination. However, there had been unanswered questions surrounding defaulter tracing, and most especially on 1. Records documented on the number of defaulting children, those that had been traced and those that were vaccinated after being traced. 2. Reasons for defaulting children in facility zones. 3. Whether this information was being utilized in planning for social mobilization activities. And 4. What the process was in retrieving the information from the community, facility, and district levels to ensure that it was valid for decision-making. In the quest to respond to these questions and ensure validity of data, an idea emerged on how to develop tools which could work hand in hand with the community immunization registers and could be used at all levels of district structures. The concept behind them was that they should be very simple to use by CBVs, facility staff, and district program officers, and should support evidence-based data on defaulters. This called for collaborative efforts with support from district health directors, district nursing officers, district community engagement officers, civil society organizations implementing the Gavi HSS, and some community volunteers who were constantly engaged during the development process. The tools include the Community Defaulter Tracing Tool, Zono Tool. This gives demographic information extracted from the community register, reporting timeline, the total number of defaulting children, the total number of children traced, the total number of children vaccinated after being traced, reason for defaulting children, and challenges faced when tracing these children. Volunteers were allowed to express their comments in any language they were conversant with, and to promote sustainability, hard-covered books were provided for each zone to prevent the burden of facilities printing out paper on a monthly basis. Prior to the submission of data to the facility, a member of the NHC is required to check the validity of data coming from their zone before approval by the EHT or any facility staff receiving this data. The Facility Aggregation Tool. From the community, zonal data is then taken to the facility, where it is aggregated on a quarterly basis and general comments are given from the facility. After being approved by the facility in charge, it is sent to the project officer from the civil society organization and the district nursing officer or the community engagement officer. The District Aggregation Tool. Once data has been received at district level, it is aggregated using the District Aggregation Tool by the project officer approved by M&E. The tools were first piloted in Chansali district, where successes and challenges were noted and worked on. Later on, they were rolled out in all the other HSS implementing districts. The end results include 1. Enhanced planning. The tools have helped recognize the real reasons behind defaulting children in particular zones and facilities, thus supporting evidence-based planning grounded on needs. 2. Traceable data. Because the process of the data undergoes from the community to the district, we are assured of being able to trace it back and to check its validity and reliability from each point of consolidation. 3. Enlightenment. The tools have brought to light the need for CBVs to seriously consider defaulter vaccination, as some admitted ending on tracing. The other aspect that brought them excitement was the ability to express themselves in whichever language they were comfortable with in the comments section. 4. Simplicity. CBVs found the tool simple and easy to use due to similarities with the community immunization registers. And lastly, 5. There is improved data sharing and community data ownership. Through these defaulter tracing and vaccination tools, we can strengthen the uptake of immunization services. From each neighborhood health committee, the community register is reviewed during the quarterly meetings between the facility and the community-based volunteers. Information from the community registers and the defaulter tracing tool is reviewed and aggregated in order to establish and document the reasons why some children have missed their vaccines. This information helps the facility to plan for the subsequent intervention. Is it the awareness that should be raised through dramas and community games? Is it the myths and misconceptions that should be addressed by traditional and religious leaders? Or is it the long distances that should be shortened by increasing the number of community outreach programs? The intervention is arrived at by aggregating the common reasons why children are missing their vaccines. The community-based volunteers then make follow-ups of the children that have defaulted and link the children to the facility and ensure that they are vaccinated and documented.